Okay, I think we're at 7:02, so we will get started. Welcome everybody. I'm Naren Nadir. I'm the residency program director at Kaiser Permanente Central Valley. And this is my colleague, Dr. Stumpfig. Would you like to introduce yourself?
Hi, I'm Nathan Stumpfig. I'm the APD over at the Kaiser Permanente Central Valley Emergency Medicine Program.
Today we're going to be talking about interprofessional in situ COVID-19 preparedness simulations, program implementation and lessons learned. So in full disclosure, we have none. And a little bit of a background regarding us. Next slide. Before we go, the learning objectives. So we want you to be able to describe the process for developing an interprofessional preparedness simulation training program and discuss the impact of what COVID-19 in situ simulation did on our patient outcomes and be able to list the effects of in situ simulation training on staff and patient safety. And finally, come away with 2 methods for tracking simulation training impact and outcomes. So those are our broad objectives. Now, a little bit of a background for us. The novel SARS-CoV-2 virus made a significant clinical, financial, and psychosocial impact on patients and healthcare providers. Clinical knowledge regarding management was rapidly evolving when COVID first came on the scene, and peer-reviewed publications were quite far and few in between. Treatment guidelines were rapidly switching, and there were drastic paradigm shifts from the time that we first saw COVID to when we understood it a little bit better. Next slide. So in that setting, let us give you a little bit of a background. So we know that it had 11.6 or probably even higher positivity rate for healthcare workers. There was a huge concern about resource management. We were running out of PPE in places. They were running out of oxygen and non-rebreather masks and things like that. There was significant concern for worker burnout and loss of productivity. And of course, with people getting sick, there was definitely people calling out sick. There was also massive disinformation, pretty rampant on social media. Next slide, please. So I wanted to go ahead and give you a little bit more of a background about who we were. So we are a little community hospital with about 60K visits a year in the Central Valley of California in Modesto. We are a part of Kaiser Permanente Northern California. And when the COVID pandemic hit and was declared a pandemic in mid-March, we started getting regional efforts from organizations about what the optimal treatment strategy was. Multiple efforts were made to disseminate the latest practice and treatment guidelines through virtual seminars and presentations, and the attendance to these events were fairly consistent across the board. Yet, on the ground, we were not seeing the application of some of the most up-to-date practices reflected. And due to the discrepancy in latest management guidelines and the practices being observed on the ground, we realized that something fundamentally different needed to be done. Next slide, please. So this is what it looked like. We saw and felt that we had a little bit of time before we got hit by a wave for this pandemic, and we could see this train literally coming towards us. And we were on the train tracks and figuring out how we get out of the way. That's what it felt like. We desperately needed to act. So what we started to do is we realized that something fundamentally different needed to be done. Next slide. And then we started getting all our stakeholders together. And in this capacity, we got the ER leadership because we were in the emergency department, right in the front of the battlefield. We got our hospitalist-based services, our internal medicine leadership involved. We got quality and patient safety involved. We got critical care leadership on board, nursing leadership, respiratory services, and anesthesia, and whole sort of 360 approach. And we sat down and we started brainstorming for solutions. What can we do best to ensure quality of care for our patients and the highest safety measures for frontline workers while being responsible stewards of limited resources? So how do we play this? What do we do? Because the message that is being sent out by virtual presentations sometimes is not getting through, and we're not seeing the practices transmitted. Next slide. So then we started thinking outside the box, and one thing that became very quickly apparent to us was that one potential solution for really having a impact on a practice could be simulation. And we started to do a little bit of investigation about simulation, and I think this is where it gets really interesting. Next slide. So if you look at it, there is plenty of literature out there which already has established simulation, the role of simulation for patient safety and quality improvement, for improving teamwork and communication, for high acuity, low frequency events. Can you press the next slide? So if you think about it, from a high acuity, low occurrence event, COVID is a once in a generation pandemic. Ergo, this was a perfect situation to test out for the case for simulation. We started to figure out ways to use simulation for road testing new workflows, for upskilling our emergency staff and our respiratory staff, specifically with respect to what precautions needed to be made for airways and things like that. We started working on the concept of deliberate practice. And then we also, started to look at it from the perspective of worker and job satisfaction, because these are all areas that we know that there's already a precedent set by simulation. Next slide. So this was the hustle. And I think sometimes this can be a little bit difficult to understand. But what we needed to do was basically demonstrate to our stakeholders, which were essentially department chiefs, emergency medicine, critical care, anesthesia, RTs, patient care techs, and nursing. We had to figure out a way to get them time, because this was a very fundamentally important part of the training. And we really wanted to get them the time to come to it. So how did we manage that? Well, we strategically started scheduling these sessions about an hour before their shift time. So when nurses and techs and doctors were supposed to be on their shifts, we started scheduling this an hour before their time. Or for when we were doing this on the floors for our ICU and inpatient teams, we did it during lunch hour. Participation was ensured by leadership. So we made it very, very clear that this was not something that, we wanted a optional attendance. We really wanted everybody to attend as much as possible. And how did we ensure that participation? Well, we gave them continuing education credit. We also gave them communication credit, which is something that our organization requires all our staff members to go through. We assembled a dedicated simulation team. So how was this done? I was fortunate enough to have like a couple of individuals who were simulation champions within our cohort. And so we basically looked to them for assembling a dedicated simulation team. We had rapidly educated and developed 3 to 5 extra folks to come and help out with the simulation sessions. So that's how that occurred. So the next question, next slide, was where do you actually sim? Because the sim center was closed, right? Because there was no social, there was social distancing, and it wasn't considered necessarily an essential activity. So behind the scenes, we actually made the case to our leadership to say that actually this kind of simulation, which is a preparedness simulation, should be considered an essential activity, because we are literally using this to prepare for this pandemic. And so it got designated an essential activity and a mission critical activity at that time. And we were actually very, in a way, fortunate. So remember the slide I showed you where we showed you the train coming towards us? So we felt like we had a little bit of time, because once the COVID pandemic, the news became national that it's a pandemic, for a couple of months, we had a strangely decreased ED department volumes. And we made use of that. So when we had the decreased ED volumes, we isolated a part of the ER, which wasn't really being used, and used that to perform in situ simulations, like shown down below. Next slide. So here was where the simulation was planned. We wanted to start out with a pre-brief. Basically, the pre-brief would include some aspects of what it is that we're about to do, because frankly, some of our staff had never seen simulations or had never participated in these kind of simulations. We wanted to introduce the mannequin and room setup and things like that, and make the case for why we were talking about COVID. Then we delivered the case, which was a geriatric COVID patient with increasing oxygen demand who ultimately codes. And then we really zoned in on the aspects of deliberate practice for the skills required for teamwork and communication. And then we debriefed and we observed the performance using a checklist, and we gave directed feedback about things that could be improved and so forth. So with respect to the actual simulation itself, our primary objectives were to train interdisciplinary and interprofessional teams on up-to-date clinical management of critical encoding COVID patients and practice good teamwork and communication skills, and early establishment of advanced directives and reasonable expectations regarding goals of care. You can advance the slide. Okay. Next slide. So secondary objectives were identification of knowledge and process gaps through simulation, and closing the gaps through debriefing, identification of systems issues, uncovering any latent staff and patient safety threats, and providing a forum for addressing concerns and questions regarding the COVID-19 pandemic amongst healthcare workers. Next slide. So for the pre-learning pre-brief, as mentioned before, our organization had already delivered virtual content about management of COVID on almost a weekly schedule. And so we relied on that to serve as the pre-learning and to give our learners an understanding of what COVID management was, donning and doffing of PPE. And safe space learning, safe space principle was of course discussed during this in the learner contract made, and of course the orientation of the mannequin and equipment in the So to go over the case and what we found, which is fascinating, I'm going to hand over to Dr. Stumpig.
Thank you. Yeah, so I'll take you through the case and also through some of the findings that we had from this simulation effort. So the case itself, as mentioned before, is kind of a fairly typical early COVID patient that we were seeing. Elderly gentleman with a history of hypertension, diabetes, and coronary disease who presents with shortness of breath. Oxygen saturations are low. He's febrile and tachycardic. The participants were given a chest x-ray showing bilateral pulmonary infiltrates, which is fairly typical of the COVID-19 disease. But what was important was that the COVID-19 results in this simulation were still pending. And this actually mirrored what was happening in real life at the time of our training. We didn't have rapid testing at that point in time, so most of the tests were actually taking 2, 3, even sometimes 4 days to come back. So we had to assume that pretty much every patient had COVID unless proven otherwise. So this was an important part of the case. Now, as the case rolled in, and I kind of like to think of this as kind of 3 different chapters through the case itself. And the first chapter of the case is that during the evaluation, it's kind of noted that the patient becomes slowly more hypoxemic over time. And within this chapter, there are kind of 2 goals. The first goal was to get participants to attempt different ways of delivering oxygen other than intubation. So trying things that may actually be very new to people, such as proning, the use of high flow nasal cannula, and even the use of non-invasive ventilation, which at the very beginning portion of the pandemic was shunned upon for fear of aerosolization. But the important part of that was non-invasiveness or non-invasive procedures with viral filters, which is again something that a lot of people were not familiar with at all. And then the secondary goal of this was, again, kind of as I mentioned before, to defer intubation as long as possible. The early intubation in COVID patients was proving to actually be non-beneficial and actually causing harm in patients. So that was the secondary goal of this first chapter. And as we roll into the second chapter of the code or of the simulation, the patient actually does code. And that is intended with the goal number 1 of trying to get people to do safe CPR, using things that we don't typically think of when we do compressions and CPR, such as the use of barrier devices, limiting the number of people in the room, and if anybody that's non-essential to actually stand away from the bed. I think typically we all want to gravitate towards the bed, and in this case, that's probably not the best idea. And then the secondary goal, or the second portion of the goal in this chapter is to safely intubate the patient. And what that means is using barrier devices, making sure you use video laryngoscopy as opposed to direct, stopping compressions and attaching the ventilator before resuming compressions. So again, certain things that we're just not used to doing in the normal patient setting before COVID. And finally, as we roll in towards the end of the simulation, the last chapter of the simulation is the failed resuscitation. This patient does ultimately succumb to the disease. And the first goal of that is to get the staff and to get the providers to recognize the futility in coding somebody like this for a very long period of time, specifically that the risk to the staff of being infected far outweighs any chances of any kind of meaningful recovery for a patient in this particular instance. So, that's something that we don't typically think about, but it's something that really needs to be on the forefront of providers' minds when dealing with COVID-19 patients. And then the second portion of this final chapter is addressing the family concerns. These are patients that probably haven't seen their family in weeks. The family hasn't had any contact with them. Getting a phone call in the middle of the day saying your family member is deceased or about to be deceased can be quite jarring. And so trying to deal and navigate those feelings in the situation over the phone in a time of disinformation was very challenging, and we wanted people to try to address that. So as I said, before, the case with this case, the patient ultimately does die. And at that point in time, the code is called and we kind of start the next portion of the simulation. What that involves is actually discussing the proper doffing of PPE right at the bedside, and then having each individual participant come to the edge of the door and practice and demonstrate that proper doffing of PPE so that they get a chance to practice it and understand what the motions are and how to best protect themselves. And after everybody gets a chance to do that, we retreat to the conference room for debriefing. The case debrief, we tried to keep to about 20 minutes or so. Sometimes several groups were much more vocal and they lasted longer, which was great, and it spurned a lot of great discussion. Some of the key takeaway points we wanted our learners to get from this were in 4 different categories. The first one being oxygen delivery. So the idea of doing new maneuvers and to do things that we don't typically think of in the emergency department, such as proning, such as high flow nasal cannula, and of course trying the old standards of regular nasal cannula and non-rebreather masks, and also non-invasive positive pressure ventilation. And as we move down to intubation, some of these patients do require intubation, but the idea is to try to delay intubation as much as possible. When doing intubation, using video laryngoscopy is probably a lot safer than doing direct, so getting comfortable with using video. And getting comfortable also with using physical barrier devices. And actually at this time, physicians were able to practice with the different devices that we had. The use of viral filters, which a lot of people were not aware of before COVID-19 hit. The idea that you want to paralyze your patients before you intubate rather than trying to just get the tube without paralysis, which was pretty standard practice in a lot of providers. The idea that holding compressions during intubation is another thing that typically we don't usually do, and it's a kind of a new, it's a deviation of dogma. Connecting ventilators before starting compressions, and of course wearing a PAPR or the best personal protective equipment you can have at the time. During the resuscitation, again, some of the new things that we wanted people to take away were compressions with the barrier in place. So putting something over the patient's face so you're not forcing aerosolized droplets into the air when you're doing compressions. Lacking or limiting the number of people in a room. We all know that codes have multiple people in the room, and probably a lot of them are a little superfluous, particularly in the COVID situation. Standing back as far as possible, having a door monitor so there aren't a lot of people in the room, making sure things like the crash cart are actually outside of the room. So again, limiting people in the room, and then using a compression assist device if necessary. And then finally, we wanted people to take away the idea of the calling the code, understanding what are the percentages of meaningful survival in certain types of patients, especially with COVID-19, and understanding that, making sure that you're having those early code conversations with people early in their hospital stay, if possible. And then finally, really the big thing was addressing the family needs. Even when the patient, it's pretty clear they're not going to survive, you still need to treat the family members. And in this particular time where people haven't seen their loved ones, people are doing everything over phone calls, not getting a chance to say goodbye, trying to navigate all of those things, as well as a lot of the disinformation that was pretty prevalent and kind of still is throughout the COVID-19 pandemic. So in order to kind of see if our intervention or our simulation actually made a difference, we wanted to kind of use a mixed method of results. Obviously, what was important was to gather information pre-training to see things like what types of interventions were being used before we did the training, how often these interventions were being used, and how they were being used. And then we did the simulation training. And then from there, a couple of different ways that we were able to get some results. Number one was just with learner evaluations, having everybody who participated fill out evaluations and fill out standardized questions as well as open-ended questions. And then looking through clinical data to see if basically if the learning stuck, if people were actually changing their practice or not, by analyzing the use of post-interventions resources, different types of modalities people were using to help patients with COVID-19 or presumed COVID-19. And finally, we were actually able to, in real time and through the evaluations, identify some latent safety threats that were present that we could actually address in real time and get ahead of and be able to kind of get out in front of before they became a problem. So the outcomes of our study here, just kind of going through this, the initial results, our program ran from the middle to end of April, all the way through June of 2020. We were able to train over 200 providers, and that's throughout a completely interdisciplinary team. So we were training anesthesiologists, respiratory techs, ED physicians, nurses, techs, and other ancillary staff. The first thing we did was assess the evaluations for specific recurring themes, so things that kept coming up over and over again. We were able to analyze some of the debriefing data that we took in real time and actually analyze some of the checklists of critical actions that that participants were doing or not doing during the procedure and the simulation. So just for the evaluation standpoint, learners' opinions on the COVID Code Blue simulation were basically elicited to see if it added value to their practice. The way we were able to do this is with 8 questions rated on a Likert scale. And those were, and then we actually additionally added 5 open-ended questions where we could try to identify themes and actually identify safety threats as well. So this is just an example of the evaluation. I won't necessarily go through everything, but obviously some of the themes are basically, was this helpful? Is this going to change my practice? And was it enjoyable? And were certain aspects of the simulation more or less valuable? And you can see that actually all of them seem to be pretty well received. A lot of them having a perfect 5 score, but most of them, everything being over 4.8. So people seem to really enjoy this and feel that it was very valuable. And again, this is over 200 evaluations averaged. The interesting thing that came through on these was through the open-ended questions. And just to list a few of them in the next coming slides, one of them, you can kind of get an idea of emerging themes and what people felt very valuable and what would change their practice. So the first one was list one way that you will change your practice because of attending this program. And you can see the actual sample comments on the right-hand side. But some of the themes that really came up and came up quite often through the evaluations was the use of proning, the use of high flow nasal cannula, the use of non-invasive ventilation with filters. I think all of those, number one, the proning and the nasal cannula high flow were rarely ever used in the emergency department. I don't know that a lot of people ever even really knew they existed other than respiratory therapists. And then again, at the very beginning of the pandemic, CPAP and BiPAP were avoided because of the thought of aerosolization, but the ability to use viral filters changes the game on that one. Again, holding CPR during intubation, something that goes against the dogma of what we've been practicing for many years. Significance of PPE, I think that would just really hit home during the COVID simulation. And then the idea that you're assigning team role members. This happens in codes, but probably not as frequently as, or actually maybe not as frequently or as explicitly as it probably should. And the need to have that leadership and that clear delineation of team roles was very apparent during the Code Blue simulation. And then obviously the avoidance of early intubations was something that was new to us as well. Some system issues that came up, we actually wanted to evaluate the systems issues for the simulation itself, not just for managing COVID Code Blue patients. So some of the, what systems weaknesses did you identify that interfered with this simulation? The 2 biggest ones that came up were scheduling concerns and advertising, which is kind of to be expected from our standpoint, but it was nice to see that that was felt by everybody, and the efforts the efforts that took place beforehand were not in vain, and probably in the learning portion of this, we would spend a lot more time trying to do this as best as possible. But obviously the scheduling concerns, people having busy clinical schedules and really trying to squeeze this in, and also just being aware that this is what's happening and this is how important it is, with people spreading the word and flyers and things like that. One of the other questions we wanted to ask was, what did you value most about this experience? And again, some of the example comments are on the right-hand side, but really the emerging themes that came through on this were that people loved the hands-on practice. People loved working with interdisciplinary and interprofessional teams. The fact that they got a chance to experience this with an ED physician, with an anesthesiologist, with a respiratory tech, with an ER nurse, with a floor nurse, with an ED tech all together, was really interesting, and people really enjoyed that teamwork and that camaraderie and learning together in that environment. People really enjoyed the debriefing aspect of it, and of course the applicability to real life, as this was something that was happening right in front of our eyes, and kind of getting ready for that train that we knew was going to hit. Again, as I mentioned, one of the other things we were able to learn or glean from this were a lot of latent safety threats. These came up a lot of times just in real time, and other times through the debriefing session. And it was great because we were able to actually get out in front of a lot of these latent safety threats and fix it before it became a problem. So certain things like inconsistencies with understanding donning and doffing, different places within the hospital were actually doing different protocols and different procedures. So having everybody on the same page and understanding what is safe and what is the best practice was very helpful. Certain areas of the hospital didn't run codes very frequently, particularly certain floors like med surg or telemetry. So the idea of really getting that team down for a code and understanding leadership and role assignments within a code was very helpful for places, especially those that didn't run codes very frequently. One of the things that we actually discovered during this process was that a single provider was doing many tasks. It wasn't uncommon to see one provider trying to run the code, intubate, and try to speak with a family member over a phone at the same time, which you can see there's obvious a lot of potential mistakes could be involved there. So the idea that having more than one provider in there and helping out with multitasking would be very beneficial. Inconsistent availability of equipment was a big thing that came up. So certain floors didn't have certain types of equipment in their code boxes, incomplete code boxes, and also certain things like in the glide scope within the ICU. There was only one glide scope in the ICU at any given time. So the fact that we're dealing with a respiratory pandemic, there could easily be multiple codes going on at the same time, and only having one glide scope would be a problem. So we were able to get a second glide scope in the ICU just by running these simulations and identifying that latent safety threat. A few other threats, again, variation in intubation workflows. People were using different barrier devices. Some people weren't using their barrier devices. Some people were only using video laryngoscopy. Some people were using direct laryngoscopy. So having a standard workflow of what was best practice was good. Again, video laryngoscopy workflow in the emergency department. Sometimes there were missing parts. The stylet was missing, certain blades were missing. And so identifying that and having a full and complete glide scope setup right away was very helpful. Again, kind of with most codes, there were too many people in the room. And so that was very easy to see. A lot of the barrier devices that had just rolled out for protection for people who were intubating people weren't familiar with them. And so because of that, they were reluctant to use them. So having the training and showing people how to do it made people feel a lot more comfortable using those barrier devices, as well as using viral filters and understanding what a viral filter does, how it connects, and how important it is to the circuit of ventilation. And then finally, the idea of, with compressions and CPR, of protecting your staff and being able to think about the protection of your staff before just jumping in and doing chest compressions, which is our standard, which is what we've done for years. And to have to stop and think about something differently, we noticed that was a big latent safety threat that we were able to discover through this process. The neat thing about this is we actually were able to elicit some unexpected outcomes. And a lot of these unexpected outcomes had to do with fears and anxiety over the pandemic. And I think that it was a great opportunity for people to get a chance to talk about this in an interdisciplinary team and an interprofessional team as well. So understanding that we were all kind of in the same boat, no matter what role we played in the hospital, and understanding that that you're not alone. And so a lot of these things came up during the debriefing, especially at the very beginning of the debriefing, where we asked about how people felt during the simulation and kind of what emotions were evoked through the simulation. And it turns out a lot of people were feeling a lot of anxiety and concerns about a number of things involving the pandemic, particularly the availability of PPE and other supplies. Again, this was at the beginning of the pandemic where we weren't sure if we had enough PPEs. People were using N95s for weeks on end. There was a lot of fear and anxiety about contracting COVID and bringing it home to your family and friends. There were a lot of feelings of helplessness when trying to deal with COVID patients, the idea that family members couldn't be in the room, that these people were dying alone, and that guilt that comes with treating those types of patients and not allowing the family to witness a resuscitation. I don't know what it's like at your institution, but our institution, we often let people come in during resuscitations and witness what's going on and get the chance to say goodbye to their family members. Not having that really struck with a lot of providers. And then finally, the difficulty of breaking bad news, especially over the telephone, especially in an era where there was a lot of disinformation, and having to be very empathetic about breaking the bad news to people over the phone, and understanding where the family members are, and treating the family member and their very difficult situation that they're going through. So the implication of this simulation actually reaches multiple levels. If you start with the simulation itself, just the direct benefits from a COVID simulation like this, you can easily draw parallels to a few things. Number one is the updated clinical information. People are getting up-to-date clinical information. People are getting information in real time and understanding what the latest guidelines are, which is hugely helpful. You're able to identify latent safety threats, which I just talked about. And also just the teamwork and the communication within these simulations was very readily apparent right off the bat. With this, you're actually able to see some downhill results. And those downhill results kind of go into a bigger bucket of the idea of patient safety and staff safety, the responsible use of available resources, and the quality of clinical care. All of those things that stem directly from your simulation now trickle downhill into these categories. And then from these categories, you get even more trickle down effect, in the sense that you're going to decrease errors, you're going to decrease sick time amongst staff, you're going to decrease burnout, hopefully, with all of this, and feeling more comfortable dealing with these types of patients. All of this leading to increased morale, and finally increased joy in meeting in medicine, which for us it's a core value of our organization. Joy in meeting in medicine is. And so, even in a horrible pandemic where there are a lot of fears, a lot of anxiety, and a lot of unknowns, and a lot of stressors, you can still increase joy and meaning in medicine by running these simulations. So finally, in the last couple of minutes, I wanted to discuss what the clinical outcomes were. These are still in process, but we were able to actually get quite a few numbers already to show that that we feel that our simulation is very beneficial for clinical outcomes. The way we did this so far is what we've done is basically a chart review, looking for any interventions that were covered in the debriefing and covered in the simulation itself in that training. And so what we did, as mentioned before, is look at the number of interventions and look at the types of interventions used prior to training, which was, and then after the training. So the numbers that we took were from March through April of 2020, and those were all COVID-19 patients, or PUIs, or persons under investigation for COVID, so suspected COVID patients. Remember, the training took place basically from May to June. And so then what we did was we looked at the month of July 2020 to see if there were any differences in July as compared to March and April. So again, our totals of our preliminary data show that in March through April, we had 145 cases of COVID or suspected COVID patients come through the emergency department and admitted to the hospital. July was 197, again, with those same types of patients. And so what we did was we took the total numbers, and we also wanted to measure it in percentages to see, were a larger percent of patients receiving certain types of interventions versus the pre-treatment group. And so first I'll kind of go through the graphical information here, and then we'll talk about the actual numbers. But if you look just at intubations, actually there wasn't a whole lot of change. The overall full intubations, the blue is pre-training and the red is post-training. And if you look on the left-hand side, the intubations show that about 10% of patients that had COVID or were PUI patients got intubated before intervention, and actually only about 11% after the intervention. So there really wasn't much of a change there. There definitely wasn't any change in the amount of video laryngoscopy used. It looked like people were using video laryngoscopy pretty standardly through the intubations. One interesting note going through the data, there were no patients that were actually intubated in the emergency department. So it kind of showed that there was attempts to delay intubation, but we don't have the actual numbers there, but it was interesting to see that pattern. What really changed in our perception and our data was the non-invasive ways of helping people with their oxygenation levels. So CPAP and BiPAP usage, you can see only about 5% of people were receiving any kind of non-invasive positive pressure ventilation. And after the training, 18 to 19% actually received this treatment. High flow was even more pronounced, where about 8% before treatment started we're getting high flow, and then after the simulation, over 25%, about 27% were actually receiving high flow nasal cannula. And the biggest difference we saw was actually in proning, believe it or not. Not very many people were receiving proning prior to the simulation, and after the simulation, over 60% of people received some sort of proning while they were in the hospital. And so you can see that through the numbers here, it's actually the intubations, as I mentioned before, really weren't all that different. So there wasn't any statistical significance in terms of the differences between pre and post simulation. However, the non-invasive stuff really showed quite a big change. And I think that was one of the biggest take-home points that we wanted people to get from the training, was that, really try to exhaust all your other methods before intubation, and all these possible ways of non-invasive ventilation were acceptable. And so you can see that the positive pressure non-invasive, such as CPAP and BiPAP, that was significantly more highly used afterwards in July. Same thing with high flow, and same thing with proning. So where we want to take this in the future, one of the things we realized that going through chart reviews, some of the biggest barriers that people just weren't documenting what they were doing. So the idea of the use of viral filters and the use of barrier devices was very difficult to come to any conclusions, because people just didn't document that they used them. So one of the ways that we can get around that is actually review some of the inventory records of the viral filter usage and how many viral filters were purchased and used during the different months. So, pre-simulation and post-simulation. So that's kind of where we're heading with that. And then ultimately what we'd like to do is analyze what impact this had on mortality, what impact the use of non-invasive ventilation and the push to delay intubations and trying to decrease intubations had on overall mortality for our patients. So what we took away from this, it was number one, we felt very proud of all the effort that it took from multiple people and multiple buy-in from multiple different levels. But it is possible to use simulation to test out new workflows in upskilling. It's possible to do it fairly quickly too, particularly in the event of something that you know is going to happen and you have very little time to get ready. But what's important in order to take this to the next level is early involvement of all the stakeholders. And so getting everybody to buy in from the top leadership all the way down was extremely important. I think also what was important was identifying some key players, some people that were big time simulation champions and really willing to move this thing forward, which is always very, very helpful. And of course, one of the biggest things you need is staff buy-in. And that's again throughout every level of staffing, and particularly through strategic leadership support. So getting the chiefs of the department involved, showing them how it works, showing them how it'll affect their staff positively, showing how it'll affect quality patient care positively, and then offering some kind of carrots involved with this too. So CME, as was mentioned, we do communication sessions that we're required to do for credentialing. And so getting those communication sessions involved as well. And of course, working with the scheduling. Every department has different types of scheduling. every department has different needs within their schedules. And so being able to be flexible with their scheduling and making it so it's not so much of a burden for people to come in on their day off, showing up an hour before their shift, they can do once. And I think people really appreciated the flexibility with the scheduling. And with that, we can take any questions. And thank you very much for attending the talk.